Beautiful. So with that note, thanks to all our moderator and panelists for this morning exciting session on our line of, do we start the slide? So we have a right timing for the learn from the masters with the left main intervention with high definition IVUS guidance. So that will be the goal. And of course, moderator, Dr. Chauhan, you are Nitin, Girish, Anup, Nityanand, and Suneep. I don't know how many are, but I know that Nitin, Girish, and Nityanand, the other are there. Supported by Boston Scientific India and ESCC Jaipur and Mount Sinai Fuster Heart Hospital. We had no disclosure. And basically, this is our episode number 22. 77-year-old patient who had new onset angina class 2 and had a cath done outside the hospital revealing 3-vessel CAD. They recommended CABG, he declined, and he came here. And basically risk factors are there. He is better controlled now. Actually, today his LDL is 18. It's HDL is 31. So really very impressive on the medical therapy point of view. All good with a 3-vessel and syntax score was very high with a good EF. After discussion, as I mentioned, patient declined and patient is here for the PCI. We did the right coronary, which we're going to show. And this patient today will be the left main bifurcation. Anu, you want to show? And of course, just to let me introduce my team here. Anu here on the right side, we have our 2 international fellows, Neil Patel and Prithvi. And nurses, Rekha and Will, and CBT, Asif and Habib, and imaging is Kiski. So, Anu, you.
Hello, say hello to Kiski.
Yeah, everybody say hello and let's say, Anu, you tell us what's happening.
So can we show the angiogram?
Yeah.
Yes. So like we mentioned, 3-vessel disease was seen by the surgeon, but then he refused. Distal RCA was right there where you see. Distal RCA going into RPDA was a heavily calcified vessel. We did 1-5 rotational atherectomy followed by PTCA and stenting of that vessel. So this is how it looks. Now EF is good. EDP is slightly high. This is where we are. Tapering left main. Significant LAD disease. Then you don't see the ostium of the circ well, but the large OM has disease. Proximal LAD. So we are documenting, the good old angiographic way of calcium, tram track, calcified LAD. And this is where we are. So prox LAD, significant disease in the mid LAD, but then there is a moderate disease in the distal LAD, which we don't plan to intervene in this time. We could have taken aleocranial to define ostial circumflex, but here in the cranial view, though it's not the view to look at the ostial circumflex, it looks that there is significant disease. But of course, once we finish left main to LAD rotational atherectomy, later on we can do the imaging.
All right, understand. So as we mentioned, this is the case. Let me just complete my presentation quickly. So for up to date, go to the angio presentation, and just as we said, we always show our appropriate use criteria. It's a 2-vessel disease. Appropriate basically is, although no imaging study done, patient with double medical therapy and patient with declined coronary artery bypass surgery. So with that note, let's go to the angiogram, and of course VC and Nitin, and so we can get your input. What will be our approach in this particular case? Do we do atherectomy? Do we do just IVL? And then start with the 1 stent versus 2 stent? All those questions will come up. So right now we are ready to rock and roll, advancing the wire into the LAD with this kind of a calcific lesion. A lot of people will decide after the ultrasound whether it can go or not, and then but we go it all the time. Yeah, once we have the tram track calcium in our lab, plan is to do the atherectomy and then you do the imaging, because rarely those are the cases where you try to do imaging and you may lift the plaque and patient become little acute. So this is type. Now the questionable case is different, but there's clearly 80+% lesion, and we are advanced with the Fielder fine cross, and the rota wire will change it to the rota floppy wire. Yeah. Question: you want to do imaging before or after? Yeah.
No?
1.5. Yes.
1.5.
In America, in your lab, Sunny Sharma, you always decide imaging after the rota ablation, not before that. So
Yes.
imaging is not used to decide whether to do rota or not.
That's a very good point. So yes, there are a lot of criteria on the both IVUS as well as an OCT that are highly complex. You know, when they score their OCT or IVUS score is 3 and above, should use rota. But for us, angiographic is quite appropriate. And you know, there is always a fallacies of any test you do. But to me, in these kind of cases, our approach has been so good, and we had no problem with that. Yeah, so some people say, well, you know what? I will decide if not a circular calcium, maybe we can just do the IVL, and IVL can go, but you probably will require to open with the balloon first before it can go. So here, to try to make a procedure simple and effective, and that is consistent, and that is where, as you just mentioned, approach has been that once you see tram track calcium, whether it's the 15-20%, it's in the deep wall rather than superficial. So you figure that out after you had done the atherectomy and then by the imaging.
Good evening, Dr. Sharma. I'm Dr.
Yes.
Srinivas Kumar here. The other problem, what you must have made you take this policy is basically this imaging catheters won't go sometimes. Though we wanted them to go, unless some mild preparation is done, it's difficult sometimes to track these imaging catheters also.
And rarely, you know, some data have shown that sometimes this imaging catheter can create a problem. I can tell you, I'm involved in the 3 malpractice cases done by other people, 2 with the OCT and 1 with the IVUS. One, you know, created a dissection. So those things are not benign, does happen. And particularly these calcific tortuous lesions, that's where the trouble happens. Straightforward probably does not. So this is where this approach of being the rota center, we do about 65-70 rota, which makes about 20% of our international volume, 20-25 we do, and has been very good, consistent. Fellows, we have 8-10 fellows every year. They all are trained in it, so has been working quite well. Yeah. So this is now with the 1.5 burr we have selected. Rota wire has been advanced, and Anu is advancing the pull push. Although single person can do, but we always believe, because we had to have a fellows for them do some assigned work, and this is what case is, that pull push and brought the advancer knob all the way back, and with the Dynaglide, yeah. So see that here, as you saw with the rotor glide, it's always set at 150,000 RPM, which you check before going in, and once it is there, we always teach the 3 push and pull on the top. Show the top
Ceiling camera.
ceiling camera. Yeah.
Okay, yeah. So we have this advancer knob. So we will move this backward forward. So any tension between the Teflon sheath and the burr is gone. Then after that, at the Y connector on fluoroscopy, go backward forward. You see that there's some movement. That's good. This is remove all the tension there. Now you're on Dyna. Just do a simple tap. So the burr just
Will not jump.
is ready and did not jump. So these 3 things are necessary to remove any tension between the burr. So essentially it's the wire, the Teflon sheath and the burr. All the tension is removed, and now we are ready to burr. So we can show the hemo by the side. Okay,
Yeah.
there. Slow packing motion.
And that is a tight lesion.
Yes.
Dr. Sharma, how much is use of orbital atherectomy in this type of situation?
Yeah, so key is, so orbital used to make about 15-20% of the total atherectomy volume. So we used to do about 10-12. But I think since the Eclipse trial and our own experience, the rota worked better. So we actually orbital maybe do 1 or 2 per month only now. Has significantly declined, particularly after the Eclipse trial results. Yeah.
So, Dr. Sharma, how do we decide, or how do you decide about orbital?
The orbital, yeah, very good point. So I think the imaging point of view, if you have a circular calcium, to me that is or calcific nodule. That's ideal for orbital atherectomy on imaging. But otherwise, straightforward segment is good for orbital. Little tortuous segment will be cause more dissection by the orbital because the wire of the orbital is 0.012. So just to say, we had a case just today is Friday. On Tuesday, it was a little tortuous proximal LED, and we predicted that we said, because fellows wanted to do orbital, we had not done in a while. So I said, okay, let's do. And I said, even despite the technique, we are going to see the vessel dissection, and exactly that happened. So just to say that non-tortuous vessel, orbital works quite well. And our data as well as the Eclipse data did show slightly higher perforation and of course slightly more dissection, because it's a very effective device. It caused a lot of deep cuts, which we showed very early back in our 2014-15 by 20 cases comparing rotational atherectomy versus orbital, and we found the orbital caused more deep cuts. But at the same time, it was more helpful that you have a less malapproach struts, but then it was causing more dissections and so and little more perforation. That was our paper, and it was the same thing which we finally saw in the Eclipse, that perforation rate was 1.8 versus 0.8, and slow flow. Also, that was surprise actually in Eclipse. The slow flow was higher with the orbital, but we actually in our database of 1500 plus patient, we did not find any difference in the slow flow between rota or orbital. But in the Eclipse, as you all aware, there was a higher incidence of slow flow in the orbital group. While we kept, before the Eclipse trial, we kept teaching everyone that slow flow is lower with the orbital because the particle size is slightly smaller, like 2 micron versus 2 to 5 micron with the rotablation, and there is a continuous high speed flush of the orbital. But it was a little different. But we definitely, as I mentioned, that our publication was, there was no difference in slow flow, but here we saw clearly that in the trial was. So now rota wire is there. So question comes is, we have put a side-by-side wire of the run-through, workhorse wire and imaging. Now, what is the purpose here now to leave the rota wire? One, that if you need to upgrade the burr, you can always go with a 6 French, go to 1.75. We did only 1.5. I think we could have used 1.75 in this case. But since the long segment calcific, we felt that 1.5, nothing wrong in that. Because I always say, at this time, knowing that we are combining with the IVL many cases, be smaller the burr. Smaller the burr, lower the complication. Slow flow, dissection, every deceleration, all low. And that we showed by the status trial where we used to use burr to artery ratio 0.8.
Can we show the IVUS?
Yeah. IVUS now.
Put the hemo in the side below the.
Okay, can I start?
Yeah.
Okay, start fullback. At this level, there's some myocardial breach, but anyway, start fullback. It's coming.
Yeah.
Small vessel.
Tell
Yeah,
them to show
now the
the
calcium studs.
hemo.
Yeah, something protruding inside. Nodule. Eccentric calcium. Diffuse lesion. Yeah. I see some cut. Left main. Huge size gap. I will stop it.
All right, let's study now.
Sure.
Okay. Yeah,
So
not
I
too
put
bad.
this reference is like 3-year vessel.
Okay.
Yeah. And
But did we see any cuts in the calcium? Was it a circular calcium
That's
also?
That's a
First, I
calcific
showed
nodule.
like a small calcified nodule
Nodule,
and come more proximal. Yeah, this is almost 360. And
Yeah.
I see some revelation.
Yes,
It means the surface is shaped by the loader. So loader is something. And I see some fracture maybe. And come more proximally. This part is eccentric calcium and the other half is normal. So it's a risk of population with aggressive ballooning. And come more proximally. Yeah, here's the proximal part also has almost 360 calcium. Then come to the left main.
Oh, did you? Okay, show us the left main.
Sure. So this is a level of bifurcation,
Yeah,
little
okay.
proximal. So this is a distal left main. Actually, area is like
Yeah,
10.
10.
Yeah.
Okay.
Then proximal left main is like almost normal.
So
We'll
we
make-
have a 3O balloon. Let's dilate. I think we should be okay. If we think it has not. So you're only the prox LED. You're worried.
Yeah.
That 1.5 burr was probably too small.
Yeah.
Which
Right
is
there.
okay. So as I want to mention everyone, do not be discouraged by using a small burr. Why? Because now we can combine with a cutting balloon or IVL. IVL I know is a cost issue in India, actually everywhere the cost issue. But by next year things will change. Right now, 4 IVL devices are under investigation, and once they get approved, I can tell you price of IVL will become 1 lakh rupees compared to almost 3 lakh now. And they're all working on the same concept, whether it's a laser energy or vibration, acoustic energy, all those. We actually there is a trial called fracture trial. Bolt Medical, that's what we are part of it, lead enroller in that trial for this IVL. And IVL is, great device, except in some cases it may not go, and that's where the trouble could happen. So many times you have to pre-dilate, and here you can say we pre-dilated with the Rota, and if we need to combine, we can do the IVL. But at the same time, what you can do is that you have done the Rota, you have Rota wire on the side, just bring your high pressure balloon. And if high pressure balloon has cracked the plaque, then you don't need anything. If you have not cracked the plaque, then you decide upgrade the burr or go with the IVL. To me, upgrading the burr should be almost very, very negligible, because there is no reason to upgrade the burr with the availability of the cutting balloon or IVL. So that's where we are now. Now tell us what we are doing.
Okay, so now we have a trio, but go back to the proximal LED.
Yeah, this is the point.
Yeah, so see the question is that, from imaging, suppose we did imaging prior to doing rotational atherectomy. That was a question asked. What do we gain from imaging? So if the catheter goes, whether it is OCT or IVUS. So when you're doing OCT, when you do the flush with the dye, you have to make sure that you are able to see the distal vessel. If you're not able to see the distal vessel, do not do the OCT. That means there's no flow and there's a risk of VFib at that time. But either way, if you've done it, and like here, the proximal LED is 1.6 millimeter diameter. We did a 1.5 burr. So we know that likely did not do anything for the calcium at that level. So once we do the dilation with the trio vessel, the balloon, that's the time we'll decide if we need to do IVL. Ideally you have to image again, but let us see how the balloon behaves.
Now, I think the day the cost of the IVL will become like a balloon, every case after Rota you should use IVL. Now we don't use it because of the cost. But otherwise, if the cost become the same, about balloon cost, which is 40,000-50,000 rupees, you can use every case IVL, because nothing disadvantage. Our paper also we just showed the combined strategy of the Rota and IVL is better. It's actually good, give you a little better lumen without increasing complications.
Okay, so we had opened always before you do rotational atherectomy, have a balloon ready. For any reason there is dissection, slow flow, you need a balloon handy, so you're ready to go in quickly. We had a trio balloon based on our eyes, IVUS, and then Keith's IVUS also told us the distal vessel size is trio. So
Yes.
that's what we are going. We went up to go to 22 atmospheres. Okay, looks like
Dr.
it's opened up.
Dr. Girish Godbole here.
Yes.
Yes.
I see that you still have the rota wire in place in addition to the run through.
Yes.
So are we not going to potentially damage the rota wire if we need to go back in again at any stage?
No, because remember, whenever we are doing double wire, side branch wire, you always have that. It does not damage just with the balloon.
Because it's a rota wire. Because it's a rota wire. It's
Yeah, balloon.
much more
Actually,
flimsy
balloon.
wire.
Maybe flimsy, but it's stainless steel, made of stainless steel. So actually, it is a very strong wire. So
And we leave it. I would say that we probably have left this situation maybe 5,000-6,000 times and not give a trouble. And most of the time, your goal is that you are not going to use it because your lesion has opened and you are not upgrading the burr. And also, you have created a one blade kind of score flex. That is the one additional blade. So that's where we are. Now you clearly see the lesion has opened. Although I'm not fully sure at 1 o'clock position that are we fully reasonably open, because
prox to osteal
yeah,
LED.
exactly. See this now. So this area, if you see here, we are not that area. This is the one, because what happened in the entire vessel, your MSA, minimum stent area, is the one finally going to determine what will be the outcome on this patient. And if this area is not fully open, whether you use IVL now or a cutting balloon, I would go with the cutting balloon.
Okay, now we agree with the cutting balloon,
Yeah.
but I think they might
3.25.
want to see the imaging. Let us do the
You want to
imaging,
imaging?
but
Okay.
based on our experience, we would say let's use a cutting balloon and stent it. But since we
This
have
area.
the
Take
IVUS,
the
we will
IVUS
just show
wire.
you.
Now you can remove the rota wire if
We
you
will
want.
take the rota wire out.
Now we can remove the rota wire. So just Girish, I
Going
think
back
Girish
to
asked
his
that question,
point,
right?
Going
Yeah.
back to his point, if you see it, you can show the ceiling camera. The wire is still very good. And like Dr. Sharma mentioned, we have done thousands of cases like that. We've never seen like any damage. So in the past, step bar approach was very common, not in this vessel, but if we need it, we'll remove our workhorse wire and go with a larger bar.
So that answer
When you want
question?
to-
Yeah.
Yeah, when you want to use cutting balloon, at that time it's better to remove the rota wire.
Yeah, that is true also, because then you added an extra blade, and that more blades are the one cause more dissections and perforation. So we actually had a case about 8 months ago that after the high pressure balloon left the rota and then used a cutting balloon, and there was a localized perforation, because same, it was a 3.5 balloon, so not 4 blade became 5 blades. And so,
Oh, yes, yeah,
wire came out?
Yes.
oh, okay.
Just wire. What did that
Oh.
happen?
So I think what happened is with the rota wire, it probably took the our run through wire also out. That pulled the guide big out. Yeah. But once you have created a lumen, now other question was that the cuts. So a lot of people say, well, based on the cuts, can you decide whether you need additional burr or you need to do IVL and so? I think the one very simple that once you have seen at least one cut, and this case, Kiski can tell us how many cuts we saw, but knowing that it was a smaller burr, yeah, good.
No, so let us go back just here.
Yeah.
Right, Kiski, on the whole vessel again?
No, just that area.
Okay, well, let's go. We are there.
Okay, start with it's a good landing zone. It's coming.
So usually you don't see the cut so well on IVUS. Kiski will say that.
I see
He
big
always
fracture.
wants
I see big
OCT.
fracture. Even the IVUS resolution. Yeah, this is the proximal part.
Yes,
Yeah, that part is still kind of small. I stop it.
show us. Go
Yep.
to the proximal LED.
Yeah. First, can I show quickly the distal part? Yeah, this is a big fracture. It was not before. Now it's a big fracture in the mid LED. Now come to our tightest spot of the proximal. Yeah, this is the blocks. This is the distal left main, and the first branch after that is, yeah, this might be the branch. So by the
I think we need a cutting balloon.
Okay.
Nothing has
Yeah.
happened.
3.25 cutting balloon, yeah, at
Yeah.
that level.
I mean, hold on.
still the MLD like 1.6. So it was
Cutting
no big changes on the
Rota cut. So rota cut approach, although we did our trial, it showed the rota plus cutting balloon versus rota and high pressure balloon, the MSA remained the same. There was no difference. Only problem there was that we had the same, we made it that rota bar has to be the same size, whatever you'll decide. Like in this particular case, but you can make it a rota cut approach, maybe a smaller bar. In this particular case, which we use 1.5, and then use the cutting balloon. But then there is a trial called Prepare Calcium Combo. There they used the cutting balloon and showed that they're definitely with the cutting balloon they had a better MSA. You want to go to that area?
It's exactly same
Okay,
area. Some dye. No,
Okay, let's get a stent,
no.
a synergy stent.
What? Some dye.
That's fine. It is okay. Yeah.
Synergy for you have to.
Synergy, yeah.
No, we have to do the circumflex.
Yeah. No, we'll do later. Yeah. So we did the ostial circ. The biggest question here will be that is the ostial circ involved? If ostial circ involved looks like it is, whether you want to decide based on the imaging or you just buy the better picture now, which will go into the caudal, then decide. You have to go further down.
No, it's not 3
What
to
do you
5.
want? You want to see the dye?
No, what I meant is further down is not 3 to 5 based on the imaging.
No, low
Go
pressure.
up.
We can go low
Yeah.
pressure.
Go up here. Just ostium, I want
Don't
one
you,
more.
Yeah. No. At
don't
1
you
o'clock.
want to see in orthogonal view?
No, means once we do the ostial, once we do the ostial circ, yes. Here it is nicely open, but we go to the 1 o'clock position, low pressure. We are not going to go high pressure with this cutting. But yeah, that's here. Here. So this is the area where there was a dent.
No, this was fully open. The dent was only in the ostial LAD.
Ah,
Okay, down.
Okay. Go 2 millimeter further, 6 atmosphere only. But yeah, so I need many views you require. Go a little further. Yeah. So all the IVL trial has required that you do the imaging and your calcium has to be more than 180 degree, and then only you can enroll the patients.
Okay, down.
So 180, not 270, it's a 180, which becomes a moderate calcium. I think this area still has not opened nicely. You need 1 millimeter back. Yeah, just that. No, pull back.
It's okay.
Yeah.
Go there.
So those are the two areas.
Any special preference between a cutting balloon of different type like Scoreflex versus
Wolverine.
Wolverine means any special preference or that they are all same?
No, let me tell you, cutting balloon, the true cutting balloon is Wolverine.
Yeah.
So when we say, and when I think we want, I mean, at least I use this
You mean
Wolverine.
It is always Wolverine?
Yes, Wolverine. And I know there is Scoreflex, but in certain situation, now the current Wolverine, you can go high pressure, 1820, and the Flextome, which you used to have in the past, you could not go in native vessel high pressure. But now since we can go, the thing with the Scoreflex, since it is not, it's only like a single wire across, in that situation, you can go real high pressure. But when you say cutting balloon, of course, you'll use that.
Yeah, so I would say that one point very clear, that once you're talking about the ostial, that's where in the straight segment like this, probably Scoreflex, angiosculpt will give you the same effect. But ostium, focal ostium, that's where I would say that we use the 6 millimeter cutting balloon, whether it was Flextome or Wolverine. So their cases we have little preference, but anything else you can use all three of them. And of course the cost, because others are about $200 cheaper. Cutting balloon is about in America about $700, and Scoreflex and angiosculpt are about $650, about $150 lower. The open NC is very expensive in America. It's a $1,200. And there's no additional reimbursement, so we don't use the open NC. It's good device, but we don't use. You want to give nitro first, or you just do it?
No,
Yeah, okay. So now we are seeing the circumflex. So open NC we do not use because in our opinion that you have done the disease. Good. Let's get the fielder wire.
Yeah.
So we do from open NC point of view, you do a rotablation because there is an increased reimbursement on the atherectomy. Whether it's a laser, orbital or rotational, and there is no separate reimbursement for using the open NC or for that matter cutting balloons. So all these things we try to use a little more cost effective, because most of the hospital compared to India and America, 80% of the hospitals are losing money. And one of the biggest losing money region is the reimbursement, the way they have done. Insurance companies pay less money, they kind of deny the payments and so forth. So many things happen. So we always try to look cost per case.
Yeah, we all feel that this proximal ostial LAD, with this, as of now, you have done your best. But I think we should make it better before we put a stent.
Okay.
So in absence, even whatever your IVUS shows at this point of time, maybe you have to take your cutting balloon once more and keep partially in the left main and then inflate.
Okay.
We did that.
Yeah, we did earlier, but we'll see. We're going to see the angiogram. Let's go to the circ first. Yeah.
Let's make sure, because we can be doing the same thing.
You see that?
Yeah.
Right there.
Dr. Sharma,
Yeah.
Dr. Sharma, from the Wolverine specifically point of view, and as a teaching to the younger cardiologists who are here, I have few that typically the inflation deflation of the cutting balloon is recommended to be very slow.
Yeah. So particularly when you're doing a second find.
Second or so.
Exactly.
Yeah. So,
but you did it much faster. What has been your experience? It makes no difference. What is the speed of your inflation and deflation?
So no, but that's very good. Actually, in the beginning when we started using the cutting balloon, we were very slow in the same process. As you mentioned, inflation, deflation. There are a lot of people believe that it should be little, even you do a oscillation. A few of the trials of the cutting balloon has required we have been involved that you do oscillation back and forth and a few seconds and so. But second, when you redo inflation, when you advance it, when you do a redoing it, that time definitely you go slow, because then enough time for the balloon to come off the blade, otherwise you will have a higher perforation. But having going for the first time, I think less of important. But let's say if we have to go back cutting balloon now, then we are going to go very slow. And so second time, yes. The first time, because the new balloon at that time is okay. But when second time, when you're trying to do the inflation, deflation should be slow. Absolutely great point.
And there's a risk of
Probably
a perforation of the device, means it may rupture. You understand? The blades, sometimes you have a balloon that is not fully deflated and you're trying to open it quickly, it can just rupture. That's it. No. Somehow there.
We have to go to that OM1, Lil Die. This is the fielder wire. Probably lost his curve or became too much curve. We need to go to that OM. Because OM has a tight lesion. And I think this will be the good case to demonstrate that ostial circ is involved or not. Once we are there, we are going to give you the IVUS again.
From the IVUS of ostial LED, what is shown seems to be not very much disease that circumflex origin.
That is correct. That's a very good point. Yes.
And there is no eyebrows.
Yeah, but you remember when you are doing the IVUS of one vessel, I mean, assessing the side branch ostium is not ideal. You truly have to do the imaging of that vessel. So let us see now.
Which we are doing it now. So clearly that your prediction that there is no disease, I also say there is no disease, but let's see. Angiographically always look little hazy. I thought it will be about 60%, but if it is not, I think it make case a little simpler. If there is no disease at all at the ostium, we put a stent in the OM and put a stent across, rather than doing a kissing. Doing a mini crush and so.
So, Dr. Sharma, putting you on the spot, based on the current angiographic picture, would it be a crossover and single stent strategy or dual stent strategy up front?
I would say that my always feeling was dual stent strategy, that there will be a circ lesion.
Less calcium.
Is it yes or no? We'll know it in few minutes. Yes.
Yeah.
Sure. Yes.
Okay.
Yep. You got
No
it.
disease.
I think
All right.
even if you can leave the LCX OM, the
nothing.
MLA may be actually not significant.
No, let's see the OM lesion.
OM is significant.
No, but
ostium is not.
Yeah.
Made sure OM is significant.
And
this is what?
This is the ostium.
This is also, the point is this kind of angulated ostial circ, sometimes it's not coaxial by the IVUS. It's one of the limitations of the IVUS of this kind of angulated.
Show us the OM lesion.
Oh, sure. So go this is a mid of
We did not do the OM?
Yeah, we are. There is a OM. Go further down, there's significant plaque.
Yeah, this is the start of the provoke, like a 2.75 vessel.
Okay, and then?
And then the eccentric plug, plug,
look at it, very tight.
Yeah, lumen is definitely tight.
Yeah.
Interestingly, calcium is just 90 degrees.
2.75 20 balloon, right?
Yeah, we just put a stent in the OM and stent across. Keep it simple.
Oh, sure.
So I think this is the IVUS definitely helped us here to say ostial circ looks good. We are going to do but first we need a regular balloon, right?
For the regular balloon.
Yeah.
What's the size?
2.75. He said 2.75 20.
Okay.
And then we put a stent.
Just put a stent.
So that's a good point. I know they put me on the spot. I thought it will be a double, and that's what we announced it. We'll do a mini crush, but mini crush became bye-bye. It will be just a stent across. And that's okay, because we learned that no matter what you do, if you have there is no disease of the ostium of the circumflex, straight crossover will definitely give you long-term better results, rather than putting a stent and then you doing a kissing balloon and so on and so forth, which can be done. But if there is no disease, why we want to do it? So in this particular case, circ looks good. We are opening the OM, putting a stent in the OM and then followed by a stent crossover, and use a long stent from the distal left main to, because truly there is no disease in the left main. It was ostial LAD, correct, Kiski?
Yes, there is a plaque, but area
Very
is fine.
little plaque. So distal left main to the mid LAD.
Okay, now Kiski left main was 4O.
Yeah, proximal part. But point is the lesion length. Actually, the mid LAD landing point to the ostial LAD is 33. No, 35. If you one stent 38, it's going to be on the plaque of the left main. So one stent 38 or two stents separated.
No, 38.
Yeah, and
14,
reference
16,
is like 3,
20.
maybe 3 or stand, but left mains vessel size is more than 4 low, so like huge size gap.
24. 275 itself, right?
Bring a 275 24 synergy. And bring a 3.5 or 3.0. 3.0.
No, that's why I'm asking.
32.
Distal vessel is 3O LAD.
3.038. Yeah, that's fine. 3.038 and proximally will pot with the 4.0. You can always increase by 1. I know they all signs. Every sales rep says my stent can go from 3 to 5 and all this. We all know that more bigger you make, stent coverage area will become less. So I never go beyond 1 millimeter. If there is a question of beyond 1 millimeter, then we'll put a 1 stent just from the proximal LAD to the mid LAD 3.0, and then from the ostial LAD to the mid left main, use a 3.5 and so. So I think this here 3.0 38 will be good, and proximally will dilate with the 4.0.
38 will not cover.
No, not 38, then say 48.
No, if we are starting from mid left main and going all the way to the LAD, you need 48.
48.
Yeah.
But according
It's
to
not going to
Kiski, but Kiski said different. Okay.
No, he said 38 will sit on the plaque.
Yeah, yes, correct.
Yeah, he said, which is based
one
on
by one first. Let's do the OM first. Yeah.
Yeah. 24.
Yep.
What Kiski is saying is, if you take 38, it will be in the plaque, and look at the angiogram of the left main to LAD. So
But
if
is
you are
that
covering,
the no? I thought the Kiski said if you use 33, it will be in the plaque. 38 will be good.
No,
Right?
sir.
What tell us what exactly the
Sure.
finding on
So-
the imaging is.
Distal landing zone, normal landing zone, to the ostial LAD is going to be 35. So if you cover to the left main, 38 is just 3 millimeters sticking to the left main. And that point is on the plaque. So 38 is going to be on the plaque on the left main.
Oh, 38 will be on the plaque.
Yes.
Oh, then we use 48.
no, I know imaging, but even looking at the angiography, look at it.
Then why
38
don't we
will
use
be
a
too
two
short.
separate stents? I think to use two separate stent.
Yeah.
Why don't we use a 3.0 28 and then we can use a 3.5 18? Yeah, that probably will be better.
We are going with the EYE now.
Yeah. Good. Okay.
IVUS. EYE. Good. Now go up.
Good.
Yeah, go.
Putting two stent will be better option.
Yeah, I think the better
done.
option. I agree.
We are trying to.
There's so much the disparity.
Okay, then get us a 3028 first.
3.028 first.
I was trying to see if we can do it in two stents. Okay. And then we take then you turn the
Take a picture.
4.0 proximal.
No, 3.5. Good.
Okay, good.
Yeah.
Okay, 3028.
Yeah. So the question is, in America, so what we do is patients with complex cases which require admission, we call DRG, diagnostic related group, and based on the complexity of the case, you get a reimbursement. So let's say this kind of patient where they have a uncontrolled diabetes, creatinine is high, the ejection fraction low. So good reimbursement in a straightforward case for the admission for the rotational atherectomy could be $25,000. But if your complex case, which we call major complex comorbid condition, MCCs, that 25,000 may become 45,000. But whatever equipment you use a 1 stent, 10 stents, IVUS, rotablation, everything will become in the part, no separate billing. Knowing that India is a little different, where every device we have separate billing. Here it goes with the DRG, diagnostic related group. If you have outpatient, ambulatory PCI, which you do about 35% of cases, there you are paid for the per device what you used. compared to the DRG, which is inpatient. There, whatever you use is become bundled up as a part of the total procedure. So if you have let's say rota case, and you use a one rota bar, one stent, you get $25,000, which is a good profit for the institution. But if you use 5-6 stents, 2 rota bar, then you are in trouble. So therefore, we have to be a little cost conscious, but just wanted to emphasize little different practice pattern of India versus United States. Yeah. Tell us, AK, what you're doing.
No, I'm trying to do the stent placement.
Yeah.
Okay. So looking at the previous there and now. Okay, good.
Looks
Sandai.
good?
Yes. Sandai. Good. Okay.
Now pull back a little more, no?
No. We are going to place another stent
Okay,
anyway.
fine. Yeah.
I think we went all the way with the cutting. But
Okay,
now
good.
Okay, go up.
Go up. So then we'll take a 3.5, 20, right?
Yeah.
60, 20.
20.
3.5, 20.
Down.
And remember, I always emphasize that once you are doing the left main, make sure you have at least 6 to 8 millimeter of the stent in the left main, even if you are not bringing to the ostium because the pot. Now we just got the pot balloon, 6 millimeter available in America. We just tried few of them. We have not started keeping it yet, but we are going to keep it. It's a good balloon, which I know India has been using for a while. 6 millimeter pot balloon, we'll be using it also. And that is where always happens that this particular case will do. So now we have deployed the stent. And let's say some ST segment changes are taking place. We
Maybe
can give little
from the small diags. Remember, we have multiple diags. Which
Okay, let's get the second stent.
Do you also have a guideliner sitting in the
Nope.
lower part of the catheter?
No. Oh, yeah, that's a very good point. So what we do is, most of the complex cases, we use a long sheath. So long sheath, long sheath. Yeah, long sheath just basically allow us to have a better steady guide. Straightforward, simple cases we don't. In this case, we thought will be a mini-crush and so forth. So that's why the long sheath was used. Okay, so we are deployed one, and now we are going with the 3.5, 20.
I think there's a problem with this wire. Every time you do something comes out. Huh?
Good.
Why you want?
Not good. And we have 408.
Uh-oh. Okay.
Take a picture.
Good.
You need to go. Yeah. Good.
I'm going in a little bit. Wait,
1
wait,
millimeter
wait.
only.
So how much minimal overlap is necessary? I mean, some people told me it should be 5 millimeter overlap. Some people say
No.
No.
One strut.
One strut.
One strut. Yeah.
Yeah, you don't need that much.
Yeah. That's exactly correct, because we know when patient come back for restenosis, all the papers have shown the most restenosis in the multiple stents happen at the area of overlap. Because there, I think what happened is you have double metal, and because remember it's a very delicate the metal to artery ratio, which determines subsequent intimal hyperplasia. And once you get the extra metal, you have more trouble. Less metal also have a more trouble. So that's kind of 16 to 17% of the vessel coverage area of probably the sweet spot in terms of having a lower restenosis.
But minimal overlap, doesn't it increase chance of fracture at that time, or that is not usually the problem?
No, that's not usually the problem, no.
You don't use stent boost for seeing the extent of overlap, or your experience?
His eyes are very big, so her eyes is more than IVUS.
Yeah.
That's what we call it.
When I came there, and I was surprised that she was not using IVUS stent boost at all. That was one of the biggest surprises I ever saw there.
Yeah, that's why we keep using the word IVUS. That's our eyes are like IVUS now.
What do you want to do now?
Yeah, we don't use, because remember, I'm a big fan of radiation. For people like us who are very high volume operators, we got to protect ourselves from radiation. And so this stent boost and all that, no matter what, even with the this is a new lab, but even then, radiation dose is very high.
Take the wire out. Yeah.
Yeah.
Radiation dose is very high. In the same way, the multiple views, multiple projections we now don't use. As a part of the trials, you have to do a orthogonal view picture before and in the end. But otherwise, 90. Those who have attended our these live cases seminars, that we use 90% in single view. Yeah, this is a pot balloon 408.
Oh, this is a pot balloon?
No, pot means for the pot procedure. We don't have the pot balloon. Sorry.
Exactly. We don't
Yeah,
have
yeah,
that. How did it appear?
Yeah, no, we don't have the pot balloon, but maybe next time we'll show the pot balloon here.
Okay, and then you see what we do. This is, we bring our, okay, we'll just go on the, good, right?
Yeah, it took more in a little bit.
Yeah, that's it.
Hmm?
Yeah, go up. I went in.
Yeah. And ready for the IVUS?
Yes.
Right. 16 atmosphere. It is a left main is 40, right?
Cool.
Yeah,
40.
lumen is 40 is good.
20. Okay.
So
Down.
my thought process goes in this way that if you are doing a live stent boost, inflating the balloon,
Yeah.
probably you can
Low pressure.
distally
Low,
keep
low,
your
low.
balloon marker in the optimum position at the carina.
Down. Yeah.
No, that is, yeah, absolutely. Agreed. Yeah, but question is, do you need a really stent
Yeah,
boost
that
or you
level.
can just do it based on the simple your fluoro or simple even cine if necessary? Because we all know the stent boost, live stent boost, even then, old stent boost used to be very high in terms of radiation. Even the live stent boost is slightly more. But yes, all these things with the newer equipment, newer devices happening, and I know that the developing the brain tumor, brain cancer for interventional radiologist and cardiologist has been a big issue globally. We see many patients, many doctors, even in America, Canada, of course, India. So had to be particularly with a busy person. Those things are very, very important.
And moreover, live stent boost, I
Yeah.
find there's a small
Check
time
the
lag,
image.
Yeah.
Yep.
and
Okay, start
I
playback.
don't find it very useful.
It's coming.
Okay.
Put IVUS on the main screen.
Nice transition. This LED looks good. Yeah, stent looks expanded. Some crossing behind. Blocks LED. Yep. And left main.
Okay,
Yeah,
beautiful.
I'll stop. Yep. It's on the plug, but looks good.
Okay, let's see in the
So,
step by step.
Can I ask you what is
Yeah.
your typical pullback speed with the HD-IVUS now that you have high speed pullback available?
So we
What do you
are,
usually
yeah,
use?
we are at 4.
4.
Yeah, our default is 4. Yeah.
Yeah.
Some
Yeah.
some doctor likes one slow pullback to watch, like slowly.
Rarely, if you really need to analyze, I go back to 1. We used to be 8, but then I think 8 was a little bit too fast. We are now at 4, so it's constant at 4 all the time.
And I know that HD-IVUS is also available in India now, right? Many places this Avigo has come.
Yes.
Yeah.
Yes.
Yeah, and actually we just going to get, when I'm going on 10th, we're bringing that Avigo in
What is that?
ESCC also, yeah.
Ostial?
Yeah, so the point is our tightest part, proximal LED, electric shake, but the lumen area is like 7. Like
No,
6
we
point.
need to dilate a little more, no?
This is a proximal LED, our tightest part. But area is like more than
We went with
5.5.
4.0.
Okay.
Both it looks good.
No, the more important, the stent is well opposed. I think
Yeah,
it's
of
just the vessel. Look at that. If you look at 7 o'clock position, right? The stent is opposed to the vessel wall.
Yes.
So the higher you go, there's a risk of perforation now.
Well, I mean, the point is, the stent is well opposed, but has it been fully expanded? So that is the question. And left LED should be at least 7.5. Are we 7.5 or no? We are 7.
Yeah, 5.5, more than 5.5, because it's a 360 calcium part. We did a rotor and cutting balloon. That's why it's still elliptical shape, but area-wide like 7. It's more than
7.
5.5.
So are we okay with the 7? I mean,
Yeah,
a lot of
yeah,
people
it's LED,
will
it's
stop
not-
it at 5.5. Some people go 6.5.
Yeah.
All those numbers keep increasing, keep bigger the better. And so, so let's say the good angiogram. Let's take the angiogram.
Ostial LED always close to left main. I think 7 is a good number.
Yeah, get the.
And since he's talking eccentric plaque, I don't think we can do much.
Yeah. No, those
If
are
you really want something, you'll have to do IVL on top of it now.
Yeah, so question, a very good point. Now you have a stent has been placed. Now you have see that some area of the stent has not been expanded, which is not the case. Then you probably would do a high pressure or IVL. A high pressure focused with the 8 mm balloon will be reasonable also, but I think this is good. This looks quite good. If everybody agrees, we can just show the last AP cranial picture with the nitro and so take the wire out.
Yes, yes, yes.
Can we take a caudal to see what's happened to this costume?
Yeah,
Just in
okay.
Yes, yes, we
Yeah,
will.
well,
We'll do
is
one
good,
cranial,
but
Yeah,
we'll see,
will do.
we'll see.
Very good point. Yes.
Okay, a little bit diag flow is decreased. Go.
Now you see the diag has become, there is a little bit of EKG changes if you see because of that small diagonal which has kind become subtotal.
Yeah.
And we are going to go back and see what size it was. Just let's see. Oh,
No,
let's
it was
take a
very,
picture and see.
it
Yeah.
was less than even a 0.5 millimeter vessel.
Okay.
Tiny.
Yeah. This is for the ostial circ. Little pinch, but yeah.
Clot shifting.
Pre-post looks the same to me.
Yeah. So let's go to the LAD. How was it?
Yeah. No, no, no. Okay. There.
Yeah. And this is the diagonal, which has become subtotal. See that angulated diagonal on the top, 1 millimeter vessel of 0.75, and this is what we have seen now.
But many times when you come back next day or the day after, sometimes it gets opened also.
Yeah. No, they're definitely with anti-platelet therapy, and some of them happen because of the spasm. If somebody having EKG changes, you see the EKG, put the EKG on the main screen. Earlier there was little ST changes, but there may be a very small AVL little elevations, may EKG on the main, and ask the patient if having chest pain. Because always I go with the patient's symptoms. Because I can say that you can go through the stent struts, but I can guarantee you'll deform the stent. Even if you do a kissing balloon in the end. So if you can avoid, and that is where data have shown, even in the left main, you stent across, patient does not have circ disease, you're doing a routine kissing, although that's a part of the EBC main, but from the Excel trial, we showed that routine kissing in the single stent across was associated with slightly higher stent thrombosis, although there was no difference in TLR. So in this case, if there's no chest pain, no clear-cut EKG changes, show the 6-lead EKG, please. Yeah, yeah. A
So
patient says
there
no
will
chest pain, then you can
be-
leave it. Yeah.
No, that's fine.
Too
So
small.
we are accepting a peri-procedural engine elevation at the cost of good long-term outcome. So a controlled myocardial, if it is a fast diagonal, your approach would have been different, I hope.
Yes, absolutely. That's a very good point. So since it's a small vessel, I think whether first diagonal or later, the question is the vessel size 1.5 above or less than 1.5. So this one is less than 1.5, and that's what Anu also felt that there is no reason to go for us to go after. In this case, if you want, we can give one bolus of integralin. All the 2B3A have shown to improve the side branch patency back in the era of the 2B3A, which we don't do that much. And secondly, this patient is a diabetic patient. We did the RCA PCI with the Clopidogrel. And
PRU is 193.
And then what we do is, ideally, those patients should be on a stronger P2Y12. I know ticagrelor is very much preferred in India. We use quite a bit of prasugrel. But then this case PRU was done, which is 193. So which is anything less than 230 or 208 is quite good. So it probably doesn't matter. So we'll continue the Clopidogrel. So if we are going to a 12-lead EKG, let me tell you what we are going to do now. Patient has no chest pain. There is still a little bit of a kind of actually EKG is subsiding now, looking normal by giving the medicine. We still do a 12-lead ECG. If there is some changes, we'll give one or two boluses of integralin 10 minutes apart. Otherwise, just one bolus of integralin after good closure will take care of that CKMB release, which otherwise happens about 2 or 3 times in these cases, even with a small vessel and so. So with that note, if everybody agrees, we stop our presentation for today. Hope we had a very lively discussion. And thank you all our moderator and panelists. And hopefully, if our audience want to have any questions about the procedure done, knowing that we are now going to have a 4 or 5 didactic lectures, we can answer those questions subsequently. Unless you you have any question, yeah.
If you agree, we'll ask you right now.
Yes.
There are a few questions from the board.
Sure.
Say one question is by someone, what precaution you take so that the rota wire doesn't come out while bringing out the rota? That was one of the question from one of the audience or anonymous.
Yeah, they are very simple. The key is that you have to one fluoro and one advancing the wire. When you're now you start pulling up, but too fast, wire will come out. So you slow down. So you are just watching it, bringing the rota bar out when rota wire leaving the rota wire in place. Second,
No, essentially the first and the second operator needs a good coordination.
Yeah.
You see that? And I always tell these people, don't go to Timbuktu, because the first person is, yeah. So see my hand movements, if you can show the ceiling.
Yeah.
I don't know if you have seen it, right? The ceiling. Yeah, so you see that? I'm just, the first operator is just taking out the burr like this. Many times you do nothing. You don't have to do anything to the Y connector. Keep doing. The second person, you do the brake release and you keep advancing. You see that? That should be the hand movements like that. And you both stand here. That will circle the bar, the Teflon sheet bar that's coming out. It will just circle here, and no need to be moving like that.
Yeah.
Somewhere. Yeah, just stay there.
and that also, there's a very good point actually, the person who had asked that question, and had happened with me the last month when I did a case at ESCC. My associate forgot to press the brake release. You have to press the brake release. So once you don't press the brake release, wire will come back because it's stuck. So that's very important. You have to have a brake release. So that is another reason when the wire comes back, because you have not pressed the brake release on the rota bar.
I have a question for Dr. Sharma.
Yes.
I am Dr. Kalra from Pune.
Yes, Dr. Kalra.
So you said that smaller the burr, less the complications.
Yes.
Some people have expressed an apprehension that smaller the burr, more the chances of a stuck burr. With your vast experience, I'm sure you'll be able to guide us on that issue.
So no, that actually what in the literature have been is only 1.25 bar. But a smaller bar, I mean 1.5 or 1.75, even in the 3.5 millimeter vessel. So we are talking about 0.3 to 0.4. But we will have answer for this question soon also, because we are working with the rota that there will be ablative surface, not only the forward of the cone, proximally also. So problem is that we had done I have gone twice and did the wet model, and turns out to be, despite putting the ablative surface proximally, only burr stuck happened 1.25. Not 1.5, 1.75. Therefore, engineer of the Boston Scientific is redesigning that what to do, because that is the most common burr in the literature, although us is 1.7, 1.5. But yes, the idea there is that 1.5 or 1.75 burr are very good, and don't be bigger. We need to combine with a cutting balloon. Not enough, then add IVL. And as I mentioned, IVL prices by next year. Take my words, by December next year, we'll have 3 companies, and actually already Merrill already have the IVL there. So all this cost will go down to less than 1 lakh rupees.
Important point, going back to how to avoid a stuck burr, is we showed the 3 steps. So very important, we follow those 3 steps, and slow pecking motion. I think there is this other theory from Japan, where they want to do 180, 190 and fast burring speed and all that. That's the time, because when you're doing slow pecking motion, you are getting a tactile feel, how the rotational atherectomy is taking care of that lesion. So we were able to do it. Okay, so if the lesion is really tight and then the lesion is angulated, tortuous, there is lot of calcium, means calcium more than what we have seen here, and the burr is not going forward, so means it is telling you the burr is not going forward. Never push the burr. That is why our 15-20 seconds, the timing is so important. So 15-20 seconds when you're done, so you do so many runs, and after it is still not going, then it's telling you that the vessel, there is some issue with the vessel, then you rethink rather than trying to push it forward. That is the time where I think when you are not following the steps that has been taught and you try to push, you will go forward and then not come back. That is the commonest reason for stuck burr. That means the technique that has been taught and written was not followed.
All right, with that
Can
note,
I
if
ask
everyone,
one-
yeah, sorry, sure, yes.
Sorry, one last question.
Yes.
If I may.
Yes, God bole, yeah.
In a crossover, which are the settings? I mean, the typical times when you do open the strut of the side branch would be if there is compromised flow or very severe pinching of the side branch ostium, at least 90%. Are
Same.
those the only two settings
Same.
where?
Same is, yep.
So there no, you don't find any other indications to open the struts
Nope,
of the side
nope,
branch.
nope. But remember, the Europeans say, based on their EBS, the stepwise crossover, they mentioned that every case, remember in the EBC1 trial, they opened every side branch. I mean, every case they had a circumflex PCI. But we do not, because we have the data from the Excel, like this particular case. Looks very good, leave it alone. And they do fine.
Dominance doesn't matter?
Dominance doesn't matter, no.
So irrespective of whether it's left dominant or not, you don't.
Yeah. As long as it's a
Thank
good
you so
flow.
much.
All right. With that note, if everybody okay, Dr. VC, I'm going to get ready and you start your rest of the didactic discussion. I'll join you in about 5 minutes. Thank you very much.